Thank you for the invite, and I'm very, very happy to be here today. I have some boring slide at the beginning, so and my slides are pretty small, so I apologize for that. I have nothing to disclose except that I will be discussing the off-label use of sildenafil to repair the brain of babies. You know, my journey started, and we will see in a few minutes. The thing is, for baby with hypoxic ischemic encephalopathy, for now, the only treatment is, as you guys know, therapeutic hypothermia. It's neuroprotective, so it's supposed to prevent brain injury. It has a good effect, as shown to decrease, you know, the rate of death and 18 months neurodevelopment adverse outcome. But it's not always successful, as you guys know. Up to 30% in the last trial, you know, still had brain injury. It's debatable if it's efficient or no in low and middle income country, and it doesn't repair the brain. So there is plenty of therapy out there, and obviously I'm biased because I will take you on my journey about sildenafil. What I want to tell today is the story behind sildenafil, how it came to light. And you know, maybe the message is when you get an idea, try to go until the end of this idea to see if it's a good one or a bad one, but at least try until the end. So this journey started in Switzerland. I'm originally from Switzerland. This is where I have this bad accent from, because I speak French most of the time. Switzerland is not Sweden, for the people that don't know. It's a very small country, and some people sometimes don't know where it is. Here is where I grew up. No, it looks, you know, this is where I used to go work and all that, but we have regular hospital and regular things like other country. And when I was there, I started neonatology as a resident and as a medical student. Also was a discovered patient there, and I went there. But I got very frustrated because we had baby with hypoxic ischemic encephalopathy, and they had brain injury. And, you know, like, at the time, there was no hypothermia. You know, it came when I was a fellow then, but you could repair all the other organs. You can fix them, the heart, the kidney, you know, kind of fix. But the brain, you had to say to the brain, sorry, there is nothing much I can do. And I find this conversation always a bit hard, and I was frustrated because I had nothing much to offer. So while reading and starting my research there, I find this article that was interesting, because they differentiate between neuroprotection and neuro-restoration. So neuroprotection, like we say, therapeutic hypothermia, is to prevent brain damage, and the therapeutic window is a few hours. You have to rush up to bring this baby, take it from the mom, bring it to the hospital, start the treatment, because if you wait too long, it doesn't work. The good thing, interesting thing about neuro-restoration is it's to repair the brain. So yes, you have brain injury, unfortunately, but probably the window of opportunity, nobody really knows, but it should be more like days, maybe weeks, and maybe months. So the journey, you know, I had to travel, because in Switzerland they say I was too enthusiastic. In North America, I'm too shy, so in fact, you're never what the people, you know, would like you to be. So I went to the United States because I read the book of Volpe, so I chose Boston to go there. And the first step, you know, to realize my idea of the treatment, I got the idea of the sildenafil in Switzerland because another guy in another lab worked on the lungs and tried sildenafil. And in the article speaking about neuro-restoration and neuroprotection, sildenafil was mentioned. So first step, if I want to repair the brain, I told myself I have to find whose baby needs the brain to be repaired, because, you know, no point to repair brain of a baby that doesn't need to be repaired. So the idea would be to know as soon as possible who will benefit from this treatment. So means you would need to know if this baby has brain injury soon. So first step was to find out how to put a baby, because now baby were cooled by the time I become a fellow. And so you have to scan them, get an MRI that's done, after cooling, because it's a bit too complicated during cooling. But that was, a problem, because I wanted to know sooner. So I had to bring the cooling machine to the MRI. So it's like bringing the fridge to the MRI. It's metallic. The MRI people will not like it because it will destroy the machine. So we find a simple way that everybody, in fact, could do, so that everybody could scan a baby during hypothermia if they want to know if there is a brain injury or not. We described that. Basically, we didn't do anything very complicated. We took a pillow, put it in 1 hour in the fridge, make sure it doesn't become wet because it could burn the baby in the MRI. Put the baby in it, measure temperature, and we were good to go for 1 hour during hypothermia, which was pretty new at the time because nobody did MRI during cooling. So then we wanted to see when do we see this injury. So as a Swiss, Swiss, we always do everything very organized. If you have been in Switzerland, so it's like that, and I've kept that. So we scan on day of life 1, we scan on day of life 2, we scan on day of life 10, and we scan on day of life 30. And by the day of life 1, it was a lot of rush. All the NICU, were not very happy because you have to rush the parents to get consent, you have to rush to get the MRI. And then by day of life 1, so means the first 24 hours of life, you could not see the full injury, so there was no point to do that. But by day of life 2, you could see the full extent of the injury. Same that you will see on day of life 10, same that you will see on day of life 30. So now I have found a baby who I can repair the brain. And here, I guess it's way too small, so you will have to trust me on this number. But that's our historical control. We have now run, MRI on day of life 2 on more than 100 babies. And we have shown the one that don't have brain injury on day of life 2, they don't develop severe adverse outcome, or very few of them. So definitively we don't want to enroll or repair this one. Like they may see some benefit, it's the question of the mild encephalopathy. But what we want to target is the one with brain injury, and see if we can make this one better. So then the journey took me out to Canada, because in the US I was an alien. I had to live. In Canada I'm still an alien also, but they adopted me finally and gave me a passport from there too. And I arrived to the Montreal Children's Hospital that 14 years ago didn't look like that, but now it looks brand new. So it's a nice picture to show and all that. And here I opened my lab, and finally I was able to do a mild ID that I originally got when I was a resident. So Viagra, as you know, the other name is Sildenafil, is already safely used in babies for pulmonary hypertension. It has shown, and it's used in high-income country and low and middle-income country. And he has shown to decrease mortality in this baby and to improve oxygenation. So the idea is, if it's already safe and tested on babies, so that part we don't need to do. It's already used everywhere in the world, so if it works to repair the brain, it could be used everywhere in the world. So that could be useful. So started the journey. Like the last talk, we had to start with the rats. So we had the rat model of hypoxia ischemia in the rats. So you do a carotid ligation, you put them in a hypoxia chamber for 2 hours, so that you do a big hole in their brain that look like a baby. And we give a different dose of sildenafil from the low dose to the high dose that correspond to the dose that are allowed in babies. And what we did also differently, because we wanted to do what, in fact, do the preclinical like we will do the baby. So we first give enteral, the medication, to the rats too. And then we waited. Like most people, they do immediately the treatment after hypoxia ischemia. We wanted to wait because we will have baby with brain injury. We wanted to see if, even if we wait, even if the cascade is on, then can we repair the brain? So we waited 12 hours in the rat, and then we started our treatment. You can see here, first picture is a brain, no hypoxia ischemia. Second picture is a big hole, so that's hypoxia ischemia. And then you have the free dose of sildenafil, and you can see the higher dose seems to be the most efficient to reduce the size of injury. What we find in the lab also is that sildenafil decreases neuroinflammation in the brain. So the astrocyte and the activated microglia that come there after hypoxia ischemia that are not good for your brain, it decreases them. We find that it decreases apoptosis, so the death of neurons decrease, and then we think it regenerates some neurons, and we're actually working on that in the lab to prove that at the cell point of view. And we also show that it improves myelination. So if all this effect could be done in a human baby, then it will be interesting because, you know, that's the goal, and then I will be less frustrated to discuss with these parents and say that maybe I can offer something. So with this encouraging result from the basic lab, we moved to the phase 1 study. It's on only one center, I guess mine. They were obligated to do it because I was there. They were a bit scared to start that because it was not done anywhere else. But, you know, as mentioned before, if you have an idea, never give up because, you know, there is point to see. It was a randomized, double-blind, placebo control. So there was baby received placebo, where baby received sildenafil. We allocate 2 to 1 because we figure you know, we have nothing versus maybe something, so, you know, we wanted to make sure that more people get something that maybe could do something. And then, like the only thing we were a bit scared to start with the full dose, which is 3 milligrams by kilo by dose, because the baby were on cooling, and we say maybe it will accumulate, maybe it's dangerous, you know, and the side effect of sildenafil is hypotension. And the baby can already have hypotension, so that may be a risk. So we started with 2 milligrams by kilo by dose. You can see it's a phase 1 study, so again, as my previous colleague, it's not a lot of babies. So in the first phase 1, 3 babies received placebo, 5 babies received the sildenafil. We had 2 babies in the sildenafil that had a small decrease of blood pressure, but only one, you know, the staff that is there changed the treatment and adjusted the treatment. So we find it was pretty safe, but again, in 8 babies. We measured the concentration of the sildenafil, and we see that during the hypothermia, which is the blue part, it reached, you know, concentration that we think could be useful. It's not there is not a real correlation between concentration and the effect, but at least in what was described in pulmonary hypertension, that's what we wanted to reach. But we were not happy because after hypothermia, it decreased drastically. It was not completely surprising because the metabolism of the liver, you know, start in the first week of life of a baby and make the sildenafil disappear. But that was not the good dose, so we stopped, you know, this phase 1 study, and we went to the second phase 1 study that this time was an open label dose finding. We figure we'll remove the placebo because, you know, it was not really nice to take all this blood to a baby that received only placebo because we took 13 times samples to measure the concentration all over the place. And in this one, we increased the dose. So group 2 went to 2.5 milligrams by kilo by dose, and group 1, and group 2 went to 3 milligrams by kilo by dose, which is the maximum dose you can give of sildenafil that is allowed in the baby. It's a phase 1, so we had 8 babies in the group 1, and we have 5 babies in the group 2. There is some withdrawal of care. So important to know is in Canada, you know, parents, most withdrawal of care and death of HIE are parents that decide to withdraw care if they see too much brain damage and all that. So that we don't think we will prevent. And then in this baby, so in the first group, we had a few baby because we take, I forget to say, and maybe that's important to say, is so the criteria to enter in the trial, you need to be moderate of severe encephalopathy by AEG because we find the SARNAT was not reliable. And you need the day 2 brain injury. So by doing that, you select the sicker patient. So it's not at all the mild, this one we remove. We select the sicker patient. So among these patients, especially in this group, they have seizures. Some have intractable seizure on multiple anti-epileptic. This baby can get hypotensive. So we find in the group 1, there was 2 babies, 5 minutes after receiving the sildenafil, the blood pressure decreased. And then after the group was enrolled, we look with the data monitoring, we look. And in fact, 1 hour before they receive phenobarbital, because at least in our unit, 7 p.m. the nurse sign out, 8 p.m. The doctor sign out and the medication are given. And we had done 9 p.m. To start the sildenafil because this is, so that sign out of both team would be done, but then it was just 1 hour after the medication. So we decided for the next group that we would wait. If phenobarbital was given at 8 p.m., we will wait 1 hour to give the sildenafil. And by doing that in group 2, which is the higher dose, nobody had low blood pressure, and they still had intractable seizures, some of them. You can see that by measuring the concentration, this time the big dose, was still the same during hypothermia, but then, went up and stayed a little bit more afterwards. So we at least had reached what we wanted, and we are further analyzing that. So obviously, it's a few babies. We are not powered to test efficacy, but we had to look because it's like a lot of effort to organize all that, and if there was side effect, then there would be no point to continue. So first we compare the characteristic of the baby, and that will be too small again, so you guys will have to trust me. When we compare the characteristic, what we see is first column is the placebo, the 3 other column are the free group of sildenafil, 2, 2.5, and 3 milligram by kilo by dose. So the sildenafil had lactate on admission that were more elevated, so it means that they have more severe injury. And they had baseline creatinine kinase and troponin that were more elevated. So again, that would mean that from a cardiovascular point of view, they were more sick, and that put them at risk for more injury. The other things I like to look is creatinine, is the kidney. You guys know if you have AKI, it also puts you at risk of brain injury and more severe brain injury. Sildenafil group, by chance or malchance, should I say, had like more elevated creatinine, so more severe AKI. So we started badly because they were more sick, but it's randomized, so you cannot choose. Also, this was confirmed when we did the MRI on day of life 2 in this baby. Their baseline injury were more severe. So like we classify as the Barkovich. So like a score of 3-4 is near total injury, where you have injury in the basal ganglia, white matter, and cortex. And you can see, so in our historical control, we had 31% with near total injury. So we take this group, leverage it as a control, because the placebo, we had 3 babies, but the historical control, we have 150. So we put that together, but you can see historical control, 31% on baseline and near total injury. In the group 1 placebo, 67%. And then you can see 88, 50, or 80% are near total injury in our sildenafil group. So more than 80% are, injury in basal ganglia, white matter, and cortex. So again, this is baseline before any study drug. So they have more severe injury and they were more sick. But now, here's the result of outcome. First, like there was no baby without brain injury, because obviously you have no brain injury, you don't qualify for the study. So here, and again, it's too small to see. So we look at the outcome. Again, I say mortality. We don't think we'll change that, at least in Canada, because it's mostly by withdrawal of care, so that parents will choose always the same thing. And then we look at, we put mortality and 18 months of outcome, because this is the most reported outcome, and this is what reviewer wanted to see. You can see that in our historical control, 77% died or developed 18 months adverse outcome. In our placebo group, that was again, more severe baby by the criteria, 100% had this outcome. But in the sildenafil group, on average, it was 60%. Again, it's too small number, you cannot conclude it, but this was the number. Then we look in the survivors. We repeated that the imaging on day of life 30. You remember day 2, day 10, day 30 should be the same. So obviously in the historical control, none of the baby show reduction of brain injury. In the placebo group, as expected, none of the baby show reduction of brain injury. In the sildenafil group, 70% show reduction of brain injury. And that went to some injury in the basal ganglia or white matter that they could not see. It went also for a reduction of the loss of the white matter and shrinkage that you could see. So, that did tell us that maybe it's working like in the rats. And then finally, the outcome we look is cerebral palsy in survivors, because this is important for functioning. It was 57% in the historical group that I remind you had only 31% of near total injury, so nearly 1/3 of what sildenafil group had. It was 100% in the placebo that were more like the sildenafil, and it went to 25% in the sildenafil group on average. So again, this is not p-value, this is, we cannot conclude, but this is encouraging. I wanted to show you one imaging. So upper line is a baby that received therapeutic hypothermia only, and lower line, therapeutic hypothermia and sildenafil. You can see the first 3 columns is the brain MRI on day of life 2, and I hope you can see they have the same type of injury, the near total injury. So in the first column, all what is gray, dark gray is injured. Second column, all what is white is injured. So you can see in the basal ganglia, in the white matter and cortex, they have the same injury at the beginning. Then we scan them again on day 10, day 30, and this, we try to make them come at 3 months and 6 months. But that becomes a bit more complicated because they don't sleep as well by themselves with just a little bottle. But we try anyways. And so you can see the line up. The brain is shrinking over time, lost white matter a lot, but also the basal ganglia shrink a lot, and it's hard to recognize them. On the lower line, there's still shrinkage, there's still injury, but the basal ganglia are still, a good size and all that. So that was qualitative, and what we got the impression, we wanted to make sure that to measure something and see, if we can see the same. So what we decided to do, and I'm showing just one this, is we measure brain growth. We decided to measure the deep gray matter in the area, like the area of the basal ganglia, as Kido Koro had developed, for premature baby. We decided we'll do the same for the asphyxiated baby. Like in white are the one with no brain injury. Again, we combine all the historical control that we had. So we could see there was 296 baby without brain injury in this one. Then we put all the one with brain injury treated with hypothermia together. This is 150 babies. And then in blue, we put all the ones treated with sildenafil together. That comes to 21. So you can see on day of life 2, which are the first 3 columns, there is no difference at baseline, so they are comparable. By day of life 10, both of them decrease. The one with brain injury treated only with hypothermia was significantly decreased. By day of life 13, they are again both decreased. Like it will not. It's not a miraculous treatment that will permit, to remove all injury, especially if you have near total injury. But the basal ganglia were significantly higher compared to the other one. And as you see at the beginning, they were worse. So at least this is encouraging. So our conclusion from that was this 2 phase 1 study was it was feasible. Enteral sildenafil, because we give it enteral, seems tolerated and reach concentration that were fine, even if this baby were NPO and quite sick. We think we find the maximum tolerable dose, at least it's the maximum dose we are allowed to give, and it was safe. And now we think there is a few clues that maybe is efficient, but we'll need a phase 2 and phase 3 study to prove it. So this is where the journey continue. I have a few years before I retire, and I hope I see that until the end to see if it works, because it's become my second baby. I have a beautiful daughter. This is my second baby that I've carried along, all these things. We want to now test multi-center feasibility and hopefully open 5 centers in Canada and maybe in the US if FDA give me approval. And then we want to check safety, obviously, in more centers than once. And then we want to explore efficacy. So thank you for listening until there. That's my funding. And if you want to contact me, please feel free. Thank you for listening.